Okay, so the last panelist said, you know, we should be talking to folks who are outside of dentistry. And so we're going to do that now. And I'm going to introduce Matt Salo. Matt was named the Executive Director of the National Association of Medicaid Directors in 2011. This organization represents all 56 of the nation's state and territorial Medicaid directors and serves as a locus for technical assistance and best practices. Mr. Salo spent 12 years at the National Governors Association, where he worked on the governor's health care and human services agenda and worked for state Medicaid directors at the American Public Human Services Association. He earned a BA in Eastern Religious Studies from the University of Virginia. Please join me in welcoming Mr. Salo, who will discuss Medicaid delivery system and payment reforms are transforming U.S. healthcare. Thank you.
All right. Thank you, David. Thanks, everybody, for having me here. I'm fully aware that of two things, one of which is that I'm the last speaker before either you go home or you get lunch or you start drinking early, whatever it is. And I share an anecdote. I heard a terrific speech once by Tom Daschle after he retired from the Senate, where he was telling the story when he was out campaigning once out in the heartland, and he went to some state fair type of thing, and he was trying to figure out how to, communicate to a bunch of people who are out there. And he gets up and he stands up on top of this tractor, and he starts talking about healthcare and talking about education and talking about jobs, and there's a huge crowd. And as he's talking, the crowd kind of dwindles, and the crowd dwindles, and the crowd dwindles until there's just one person left. And he finishes up his speech, and he kind of says, you, sir, I must have really said something that resonated with you. What was it? He says, you're standing on my tractor. And so Daschle says, as he was concluding the speech, I'm standing on your tractor, goodbye. So I am going to try to keep this relatively short and sweet so that I don't stand on your tractor too much. But the other thing that kind of struck me was that a lot of what I'm going to say, or a lot of what I was planning to say, really was emphasized or was brought up in a lot of different ways over the past day and a half. And I think that's an extraordinarily good thing. I'm sure I have not been doing this as long as some of you, but I've been doing kind of Medicaid and dental health kind of intersections probably for almost 25 years. And the first time I kind of got a kind of convening of state Medicaid and dental providers and feds and public health folks was a meeting we'd put together back in 1997. And the conversations that were happening then were radically different than the conversations that have been going on over the past day and a half. And I really think that's a testament to all of us in our respective work, trying to figure out how do we overcome what I think we kind of agree has been an historically not very functional or effective relationship. And it really is improving and focusing on where we need to be focused on, which is improving beneficiary outcomes. So I think within that lens, I'm going to hit on a couple of points from the state Medicaid director perspective. And again, like I said, I think you will recognize a lot of these. I mean, Mary really hit. I mean, you hit them all almost in like 5 minutes. That was amazing. However, I'm going to do this without slides. So, if you have a learning style that needs something to look at, I apologize. But somebody once told me that that power corrupts and PowerPoint corrupts absolutely. So I'm gonna stay away from PowerPoint. Real briefly, so my association, we represent every one of the state and territorial Medicaid directors. As you know, Medicaid is a big program. We covered 74 million people last year, more than $600 billion. It's 25% of the average state budget. And it has, I think, for a very long time, really struggled with what I call a understanding and appreciation deficit amongst policymakers and the public in this country. And I think there's a lot of reasons for that, but I am hopeful that that is changing. I really think that one of the silver linings, if you will, over what was an extraordinarily bruising fight on Capitol Hill in 2017 over the repeal and replace of the ACA, one of the silver linings of that was a kind of growing recognition, a growing awareness, and a growing appreciation that Medicaid isn't just some sort of other. That it isn't something, it's like, oh, I don't know, I don't like it. It's what that lazy person over there gets, blah. And that, in fact, Medicaid is us. It is all of us. We are all impacted by it. Medicaid pays for half the births in this country. Medicaid is by far the largest payer of long-term care in this country. Medicaid's the largest provider of mental health services in this country, behavioral health services. It has an extraordinary reach. And again, I think there's a lot of reasons why people don't really put two and two together, but I think a lot of that is changing, and I think that's ultimately a very, very good thing. So as the battleground for the future of Medicaid shifts from the federal level down to, I think, hopefully I can fairly say this, at the state level, I just want to kind of recap what I'm seeing, and I think assuredly what you all are seeing in the states that you're working in. And again, this is going to be easy for me because I think you've had a lot of these things reinforced over the past day and a half. So, the challenge for me is, running an association of 56 very, very different individuals and trying to figure out what are the common grounds among Texas and Washington State, California, Florida, Maine, and everything in between. Geographically, politically, they are all very, very different. But at the end of the day, one of the things that, that keeps me going is that the job description of each one of the state Medicaid directors really is pretty much the same thing. And that is basically to improve the healthcare system for the people that they serve, while also being responsible stewards of the taxpayer dollar. And then ultimately doing so in a way that is politically and culturally relevant in that state capital. And those kinds of parameters, those last two, the first two are kind of obvious. Oh yeah, better health care, serving the people. But it's the last two that I think are really important to keep in mind, because those are the kind of the real world parameters around the challenges that they face. And because, one of the great ironies of Medicaid is that it gets two major criticisms from federal or other policymakers, one of which is it's too big and it spends too much money, and the other is that we don't pay providers enough. And I have yet to see federal policymakers really connect the dots on those two criticisms, but at the end of the day, that's a challenge that we all face. Yes, we don't like paying everybody less than market value for everything. And what I have to say to every group of people who I come talk to or come talk to me, whether it's dental or mental health or physician or what have you, it's not personal. It's not just you. It's everyone. It is how we operate. And if we paid everybody more market rates, instead of $600 billion a year, we'd be $900 billion a year. But that creates a level of pragmatism and practicality that drives the day-to-day operations of Medicaid at the state level. And unfortunately, it kind of puts them in the position of saying no to a lot of people a lot of the time. We don't get to be idealists, and when I say we, I mean my members. We don't, it's like, I guess I could quote Donald Rumsfeld, if you will, you don't go to war with the army you want, you go to the war with the army you have. And so Medicaid's trying to do the best job of improving health with the army we have, which is underfunded. But I think within that, The other thing that is the commonality, the common thread across all states, and again, you heard this so many times today, is a recognition that the inherent underlying fee-for-service model of healthcare has largely failed. And that, if you're talking about people who are generally healthy, me, it's okay, it doesn't matter. But generally healthy people don't really drive healthcare expenditures, generally really don't drive Medicaid expenditures. Medicaid serves the oldest, the sickest, the frailest, the poorest, the most medically complex. The people who are intersecting with so many different traditional silos, acute, mental, behavioral, pharmaceutical, long-term care, dental, social. And in many ways, for those people, a fee-for-service system, fee-for-service abbreviated FFS, the FFS could stand for fend for self. Because that's what if you just send someone out into the world with an insurance card and say, there you go find someone who will see you. That doesn't help them, doesn't help society, doesn't help any of us. So trying to figure out how can Medicaid, and I think, to a certain extent, some commercial plans in some parts of Medicare are trying to acknowledge this as well, but we've got to change the delivery model. Again, not a surprise, you've been talking about this a lot. This is going to look, however, very different, potentially, from state to state. And you've got states where the destination of the journey from fee-for-service to, quote-unquote, managed care, the destination can look different. You can have a staff model HMO like a Kaiser Permanente, salaried professionals. Or you can have in Arizona, where you've got a whole bunch of managed care organizations, capitated model, but traditionally, even there, didn't really think about too much how they contracted with and paid the providers underneath that system. But you can have other situations too, whether it's the CCOs in Oregon or ACOs. Massachusetts has been a state where traditionally they've done a lot of managed care. Massachusetts is actually pulling back and saying, you know what? What we're paying the plans isn't getting us what we need. When we compare what we're paying them and what we're asking them to do, they're not delivering. So we're going to shift to a more accountable care organization model, which at the end of the day, in the grand scheme of things, isn't really all that different conceptually. It's still trying to create an entity that has got the full spectrum of all the silos affecting the beneficiary under their umbrella, and with the ability to change, to modify, to innovate, to improve how those services are delivered, and with a financial motivation and incentive to do so. But quite frankly, we've also got other states out there, and you may see this to a certain extent where you are, states like Connecticut, where they tried managed care years ago, completely gave up and said, a pox on all your houses. We don't want to do this at all. We're going to take, and I saw one of the questions earlier on Slido, the state is essentially operating as a managed care organization. They call it managed fee-for-service. You can call it whatever you want. Now, I don't know that California could do that because Connecticut's a very small state. They're very well resourced. They're very centralized. But at the end of the day, there's a lot of different models for how to do this. The key thing and the most important takeaway I have is it's not so much what it looks like, not so much how you define what managed care looks like, so much as what it isn't. And what it isn't, and what we're moving away from, is unmanaged care. That's my takeaway. That's what we're trying to achieve. And for what we're trying to do, there's also a recognition that this is difficult. This is easy. This is so easy for me to get up here and say this. But this is really, really hard to do. And you know why? It's because healthcare, well, first thing, Medicaid does not operate in a vacuum. Medicaid is not out on an island somewhere. It is a part of the healthcare system. And the healthcare system is 18% of the nation's economy. And we've all heard that statistic, but I think it really needs to sink in that this is 18% of our economy that has built up over decades and driven its business models based on incentives from an old system that I think has failed. So we have to figure out, how can we change that underlying system that is siloed, that is unmanaged, that is fragmented? How do we create a more holistic system? And one of the things I really, really liked about the last panel, and I think it was Mike talking about this, is that this is leadership. Calling you out. Leadership. Leadership at the state level, leadership at the plan level, leadership at the provider level. Because at the end of the day, we are talking about changing business models. And from our perspective, it's state government pushing 18% of the nation's economy to change its business practices and to change its business model. How do you do that? How do you do that in such a way that the minute you take your foot off the gas, the minute you take your eyes off the prize, the system doesn't just revert back to the way it was doing things before because that's what they know and that's easier? And the answer is doing it incrementally. Jeff, I think you were saying this too. Incremental change. I usually like to close with this quote, but but I think it fits in here. I've seen leadership defined as disappointing your followers at a rate that they can sustain. To me, that's really what this is all about. How are we enabling and empowering the healthcare system to change itself in such a way that the changes we make are going to stick and aren't just going to revert back to, well, I'll get more money if I just build a bunch more MRIs. And you know, it's a multi-step process. Because I think the first step really is you got to communicate to everyone who's involved here that the status quo is unsustainable. You are standing in the fire. You may not see it. This is not fine. We need to move out of this. That's the first step. That's hard to do sometimes. Second step is articulating a vision of where you want to be. Okay, what does value-based purchasing mean? What does integrated care mean? You've got to be able to articulate what does that actually look like, and why should we go there? How will that benefit you? And I remember, and this is not a dental conversation, but there's a great conversation I remember happening in Arkansas years ago where they were taking the first steps towards some of their value-based purchasing efforts. And Arkansas is a completely non-managed care state, so this was, how are we making this work in small 1 or 2 person primary care physician offices across the state? And they had the Medicaid director and the Surgeon General, Arkansas has a Surgeon General, out there like barnstorming across the state trying to communicate this situation. And I remember they had this wonderful little like pie chart. This is pie chart of healthcare spending in Arkansas. I don't have it with me, but you can picture this. And they would sort of say, hey, let's look at where we spend money in this state. Let's look at it, see this really big pie piece, 30%, that's hospitals. See this other really big piece, 25%, that's nursing homes. Can you guys see where your piece of the pie is, the primary care physician pie? You can't because it's 2%. You can't even see your own pie piece in this chart. And they kind of owned up. They said, you know what? We've created a system that has allowed this to happen. We have let the financial incentives drive all of our money towards these big, massive institutions that, frankly, we don't want people to be in if we can't help it. So what they were saying is, look, we are now introducing this new episodic bundles of payment. I was like, well, what does that mean? And as they explained what it would look like, they also explained what it would mean for the primary care physician. And in essence, the pitch was, you know, you are the focal point for a lot of these patients. You're underappreciated, you're underused. You have an ability to impact whether or not they go to the ER or whether or not they end up in a nursing home. But what's your motivation to do so other than, oh, yeah, it's the right thing to do? There's no motivation. There's no financial motivation for you to spend that time trying to figure out how to make this work. And so what they said was, look, we're gonna create a new payment system where, you know, and based on these certain episodes, whether it's, you know, hip replacement or ADHD or depression or birth or what have you, we've got data, and we paid McKinsey millions of dollars to get the data. We know pretty reliably what the healthcare spend would be for these patients under the current system. And it's a trend like this. In our new system, what we're going to do is we're going to encourage you, empower you to get in there and try to make some differences. And at the end of the year, we're going to look at what every patient's actual healthcare spend was. And if their actual spend was less than what our trend was, we're going to take the delta and we're just going to give you half. And then the light went on as they realized that, oh my God, within a couple years, we could double our actual take-home pay with this. Getting them to recognize that it can be in their financial interest to do things differently. But that wasn't enough, because you then have to figure out how are you going to transform your practice? How do you get from where you are today into that promised land? And, you know, because one of the things the physicians, and I think this is probably true for many of you as well, one of the pushbacks was, well, what do you want us to do? You know, how do you expect us to impact their actual outcomes? You know, I've got an office. It's got 4 walls. People walk in. They present some symptoms. I spend 10 minutes with them. I diagnose. I give them a plan of treatment. Off they go. Are they following my plan of treatment? I don't know. I'm certainly not impacting it once they leave. How on earth, I mean, what do you want me to do? Go to their house and check up on them and see how they're doing? And the answer was, well, you're not going to. But we can create something, a patient-centered medical home. And you can be the quarterback of a team, and your team is going to have community health workers and social workers, non-traditional providers, peer counselors. You better believe it that those people are going to follow Mrs. Jones back to her home and say, hey, how you doing? What do you need? And once we kind of put those things together, those changes can be self-sustaining. And that's where I think really the promise here is for all of us. It's not going to be easy. I mean, trying to figure out, we're spending a lot of time right now trying to figure out how to make mental health and behavioral health better integrated with kind of the acute care model. That's hard, but it's a process. Clearly, dental, oral health needs to be a part of that model too. But it is hard. It is getting people to change their mode of practice, change their business model, change the way they think about government, change the way they think about insurance, change the way they interact with patients. Change is hard. Nobody likes to do it. And ultimately, at the end of the day, that change is not going to be sustainable if there isn't a financial incentive inherent and aligned with it. And I think it's just, I mean, some of that is just common sense. It's, if we were to clean slate everything and say, how would you design a healthcare system today from scratch? It wouldn't look anything like what we have. But we have what we have. We have the army we've inherited. How do we transform that? How do we change it? And how do we make it? How do we figure out, because I think, you step back and you say, what do we want out of our healthcare system? We want people to get and stay healthy. Radical. But understanding that there's no profit margin anywhere for anyone by people getting and staying healthy. Understanding that is the key, is the trick to figuring out how do we move forward. How do we make it financially advantageous to a health plan, to a physician's office, to a dental office, to a hospital, where people are getting and staying healthier? This is our challenge. This is our call to action. And I think there's been a lot of talk about, what's the best model? Or what's the best, value-based purchasing arrangement? Or what's the best way to go about using this? I don't know that there is one. I think we're still a long ways away from figuring something out and saying, that's it, everybody do it. And so I think for a while now, we're going to be in this awkward spot where we've got 50 plus state Medicaid programs moving in this direction, trying to coordinate, trying to manage care, trying to create a holistic system, and trying to make it financially rewarding and sustainable in a bunch of different ways. And even when you think about kind of like macro, how do you make it happen? You've got states who are just sort of saying, we know exactly what metrics we want to use. We know exactly what kind of payment we want to use. We know what kind of balance of upside and downside risk we want to use. And managed care plans, you're going to do that. And then you've got states who just say, we know we want the plans to do something. Y'all get out there and let the competitive marketplace of ideas come up with what works. Survival of the fittest. And kind of everything in between. We haven't figured that out yet. We don't have the answer yet. And so we're going to be in this kind of awkward spot where you've got a bunch of different state Medicaid programs out there moving in this direction. But where is Medicare? Where's the commercial market? And is it realistic in any way, shape, or form to think from a realistic standpoint, from the point of view of the provider, whoever that provider is? If I'm sitting there and I've got an office and I've got a case mix of 30% Medicaid and 30% Medicare and 30% commercial and 10% uninsured or whatever, and within that, Medicare is asking me to do one thing, commercial is asking me to do two things, Medicaid is asking me to do four things because that's how many different plans are in my state. And that creates 8 different, my math is bad, whatever, 8 different ways I have to remodel my business. That's not sustainable either. But we don't know what that one answer is. And I think in all likelihood, what's going to happen is you're going to have Medicaid driving ideas. And at some point, Medicare is going to look at that and say, okay, we like that one. We're going to take it and we're going to run with it. And then that's how you're going to see at least some level of uniformity, some level of commonality start to move. And then at that point, we'll kind of start bubbling up different ideas again. But that kind of like fits and starts and punctuated equilibrium type of approach, I think is likely where we're going to see. And I think what we're seeing from this administration is some pretty clear signals from Seema Verma, the administrator, that they've got the Center for Medicare and Medicaid Innovation, and they're trying to figure out how do we harness that engine of reform. And what we're hearing from them is a very consistent sense of, we want to make sure that payers, different payers, are getting more coordinated, are getting more aligned, and are thinking about these types of reforms that are sustainable at the ground level. And I think ultimately that is a very good thing. Because, Arkansas Medicaid certainly, can't control what California Medicaid does, and neither of them has any control over what Medicare does. So to the extent to which, you do have an effort at the federal level to say, we're going to watch what's happening and see what can we learn and how can we replicate. Because I think that's been the biggest challenge, for me personally, the biggest challenge of CMMI, since its creation, is that they were just purely, it's laboratory innovation. Let's let 1,000 flowers bloom, which is great on a certain level, but at what point do you replicate? At what point do you say that the healthcare system is not going to get fixed by the same 10 states, in Oregon and Minnesota and Massachusetts and whoever else, innovating, and the rest of the system just getting further and further behind? We've got to figure out, are there lessons learned here? How can we apply those? How can we make those easily replicable as part of the system? And I've heard Atul Gawande talk about, not this specifically, but as he talks about the innovation of medicine or the innovation of technology, when he talks about it, he says the thing that is going to make any of this sustainable, any of this work, any of this permanent, is when it becomes so easy, so built into the basic background of every piece of technology, of every decision that we make. If what we're doing is, if every decision is, how do I think about, taking advantage of alternative payment models, it's still too complex. We've got to build it into the baseline. We've got to make it easier for everybody, not more complicated. So I think I will probably stop on that. And I think the quote that I'll leave you with is that the vision in all of this, as I mentioned before, trying to figure out, part of my job, how do I herd cats? How do I herd 56 cats? The parallel for me is all of this healthcare reform, all of these changes, all of the managed care, the alternative payment models, the value-based purchasing, impacting Medicaid and Medicare and commercial, dental, primary, acute, pharmaceutical. There's a lot of cats there too. And how do we herd those cats in a sustainable, permanent way? The way you herd cats, you move the food. If we figure out how to move the food, to me, that's the payment incentives. If we figure out how to move the food, we can move these cats in a sustainable and permanent way, and that's my vision for the healthcare system. So I'll stop there. Thank you.
questions, comments, reflections?
You don't get to do the anonymous Slido, I guess.
Nope, got to stand up and do it in person.
You just really want to get to lunch. Get on that flight before they close another airport. They closed LAX this morning.
Can you give us some sense of the policy environment? And like what do you think's going on? I mean, I know that if you're observing it, regardless of your perspective, you just think it's chaos. You hate, you love, this kind of stuff, and there's a lot of noise. But at the end of the day, are there constructive things happening that could be building blocks for the rest of this administration or for the next administration beyond the noise? What are you seeing there?
Yeah, I mean, I think the constructive thing, I think there's a lot of noise, and I think clearly the whole repeal and replace and block grant Medicaid effort over the past year plus was very distracting, very very confusing, very frustrating. I think there's a growing recognition that Medicaid's not going away. I think you saw in the November elections. November elections did two things. One of which is it I think put to bed any federal effort to make massive changes to the program. But you saw in very, very red states like Idaho, Utah, and Nebraska, ballot initiatives to expand the Medicaid program. And we're also seeing gubernatorial changes in Kansas and Maine starting to play out in terms of embracing embracing the expansion. I think it's a growing sense of it's going to be here to stay, and let's figure out how to take advantage of it. But at the same time, there's also, I think, a growing recognition that as Medicaid grows, and it's been growing for a very, very long time, it's now 74 million people. That's a really large number. That there's going to need to be different philosophical thinking about the purpose of Medicaid in different states. And I think Andy Slavitt calls this letting the blue states be blue and letting the red states be red. And you're seeing now a lot of different states kind of embrace things like the work requirement. That's now been live in Arkansas for a year and just went live in Indiana and New Hampshire, and is going to go live in a bunch of other states. But there is a recognition that Medicaid is not the problem, but can be a solution. But that solution is going to have to be tailored to look different ways in different states. And that healthcare ultimately, like politics, is very local. And that the sustainability politically of Medicaid, which relies on taxpayer dollars, is going to require making sure that that Salt Lake City and Boise and Little Rock have got had kind of the authority and the investment and the power to say, we can shape this in such a way that we can keep this going, as opposed to, just kind of shunting it off to the back burner. And I think there's also a growing recognition in a lot of states that, as crazy as things have been, we've actually been on a pretty good economic growth rate for the past 10 years or so. And that's not going to last forever. There's a recession coming. I don't know when, but we know there's one coming. How are we going to position ourselves to be able to absorb that when it comes? And how are we thinking strategically such that when it comes, and when jobs go away, when the economy goes south, state revenues go down, eligibility for Medicaid goes up at the same time, what kind of tools do we have to ensure that the answer isn't what the answer has been every other recession in history, what are we going to cut? Cut eligibility, cut benefits, cut provider rates. So I think there's a lot of conversation now about how are we being more strategic about how we make investments in the healthcare system to be able to withstand what I think we all think is coming, although we don't know when.
Hi, thank you. Very interesting what's going on. And I guess my question is more about provider types. We've talked a lot about workforce and all these care extenders, assistants, hygienists, dental therapists. But if you're not a provider type where you can be reimbursed for your services, you know, we would see a lot more, I think, done with vulnerable populations if we had a mechanism to be paid.
So I think I agree, and I think the answer to that is not in codifying a whole bunch of new provider types that get a specific reimbursement, because you can go down a rabbit hole and trying to figure out what that is, but rather in thinking, and this gets back into the whole sort of social determinants of health conversation, which is, in many ways, the things that are necessary to get and keep people healthy, I don't even know if you can quantify who it is that's doing that. But that if we can create, again, so this will go back to managed care or an ACO or whatever. If there's an entity out there that they're getting paid and can benefit from the downstream interventions, upstream interventions, downstream results, they'll just figure out a way to do it. So the story that I always use, and it can sometimes come across as a little trite, but I love it because it's so simplistic. I was talking to the Kentucky Medicaid director years ago, and he was talking about an experience they had where they had just kind of recently gone to managed care, and one of the things the plans would do was they would do kind of a health risk assessment of all the new patients. And anybody who was, checked a couple of boxes, they would send somebody out to their house just to do an observation, see who they were, see what they needed. And so they sent a caseworker out to this little old lady's house who lived alone at home, little ramshackle wooden, log cabin out in Appalachia, whatever. And they spent the morning with her. She's like 89 years old. She lives alone. And they're trying to figure out, okay, well, who is she? What is she going to need? How can we help? And lunchtime rolls around. So this lady's making lunch for herself. And the caseworker's like watching this, and she's cooking. She apparently has a hot dog for lunch every single day. Oh, wow. And the first thought was, ooh, really? This is not healthy. Can we get some? Can we call a nutritionist? Can we get some kale in this woman's diet or whatever? But then they're like, no. She's 89. A hot dog a day really isn't the problem. The nitrates are probably keeping her alive. Who knows? It was what they saw when they were in the house, because she was cooking the hot dog the only way she could, which was on a frying pan on the stove. And she's like 4'10", so it's like like this. And the caseworker's looking at that, and just the light goes off, because it's I know how this movie ends. There's a knock at the door, a phone rings, a dog barks, a momentary distraction, and this woman's moo-moo, the sleeve, is going into that fire, and that's a second-degree burn. That's an ambulance trip to the ER. That's a rehab stay. $30,000. We hope she's back home. That's how this ends. And so the thinking was, well, how do we prevent that? And the answer was, and so they called up home office and said, well, get her a microwave oven. And she said, well, what's the code for a microwave? Does Medicaid pay for microwave ovens? What's the code for a microwave oven? And she just says, shut up, don't ask. Just go to Walmart, buy a microwave oven, bring it in, install it, teach her how to use it. We're not going to bill for it, but we know that those types of investments are going to keep our profit margins healthy at the end of the year. We are going to pay for that type of thing. We are going to pay for your services. We are going to pay the community health workers. They don't necessarily need to be directly reimbursed by Medicaid. The plans or whatever can figure that out. And there's so many wonderful stories like that. Little things where, whether it's a microwave oven or, there's a terrific story I saw once, terrific. There's a guy who, was crashing into the ER because of just uncontrolled diabetic shock. And, this had been going on for months. And, they finally figured out what was going on. It's like, totally uncontrolled. And so they got him in a plan of care. They got him his insulin, taught him how to use it. And then, a couple months went by and they never saw him again. It was great. He's doing great. And like 6 months later, he comes crashing into the ER, the same problem at the end of the month. And they're like, oh my God, what happened? And he's like, I don't know. I'm taking my insulin. And as they went in and as they explored, as they engaged with him, they realized what was happening was, well, he was keeping his insulin in his fridge, but he couldn't afford his utility bills. So his power went out, his fridge was out of power, and so he was essentially injecting himself with inert insulin. Okay, the answer is, we're going to pay your utility bills. There's never going to be a direct line for Medicaid to pay for any of those things, nor should there, I don't think. But we're going to have to think very differently about how do we, ensure that those things can get provided.
Yeah, I think my question was more along the lines, the type of team members that can do still preventive dental services, but you don't need a dentist in there to be doing that. You have a hygienist, you have community health workers, you have CDHCs. All of them could be making a difference in that person's life without sending your top dollar professional that's getting reimbursed at a higher rate.
Yeah, I mean, I think, and obviously, and I know this was touched on earlier, but there are going to be issues state by state, on the scope of practice, what can be done, what can't be done. Personally, I'm a big fan of, obviously, and it's not just dental, but any specialty or any component of healthcare. Don't focus as much on the specialty. Don't focus as much on the super high cost provider. If we can spread that out, is it minute clinics? I mean, I never go to the doctor anymore. I go to minute clinics just because it's so easy. I mean, my kids, I've got 3 kids. They're 2, 4, and 9. And I don't know that other than maybe once or twice, they've ever seen a pediatrician. But every one of, it's, LPNs or what have you, RNs who are in our pediatric practice, who they're seeing, and it's great. We can figure out a way to do that. It is utilizing more people at lower ends of the practice scale. I don't know if that's the right terminology, but yeah.
Well, thank you so much, Mr. Salo. That was wonderful.
Thank you. You can have your tractor back.